Hello, everyone. Welcome to our latest CME webinar on optimizing diabetes care across all life stages. A very warm welcome to all of you. As you may know, Home Nursing Foundation is turning 50 next year. We will be celebrating 50 years of care and 50 more years to share with all of you. And as the largest home healthcare charity in Singapore, we are growing in our capabilities and capacity to serve more than 5,000 patients each year with home-based medical, nursing, therapy, and home personal care island-wide. Regionally, other than our wellness senior care centers and community rehab at Hougang and Buangkok, we will be opening 3 more active aging centers next year with a TCM-themed dessert cafe to provide seamless and holistic care for more aged communities. Over the years, this series of continuing professional education has helped raise the understanding and practice of quality, person-centered care to many patients in the community, empowering them and their caregivers to live joyfully. Having covered a wide variety of topics, very highly pertinent to community aged care, such as end of life, functional rehab, dementia, falls, mental health, Parkinson's, wound management, caregiver support, social prescribing, asthma, continence, in an interdisciplinary conference on palliative care. Many of the past sessions are available for your viewing and reference on our YouTube channel using the QR code, as you have seen during the slides. This afternoon, we eagerly look forward to Dr. Daphne Lee's sharing and followed by a Q&A session. So without further ado, I shall hand over the time to Dr. Ng Wai Chong to introduce Dr. Daphne.
Thank you, Christina. And warm welcome to everyone joining us this afternoon for this very useful webinar, because diabetes is really our bread and butter. And so we are very happy to have Dr. Daphne Lee. She is the medical director and consultant endocrinologist at Dr. Daphne Lee Endocrine and Diabetes Medical Clinic. Her clinical interests include general endocrinology, such as diabetes, thyroid disorders, osteoporosis, and her subspecialty interest is in adrenal and pituitary condition. And today she has specially prepared for us a talk related to diabetes across our life course, different conditions of our patients. And I'm sure this will be very meaningful to all of us working in the community, be it in nursing homes or in home care, or if you're a GP working in clinic and you're seeing your patients getting older and older, becoming more and more disabled, more and more comorbidities. How are we still, what is the target of our treatment, and what kind of treatment or pharmacotherapy or non-pharmacotherapy is proven to be useful and effective. And so let us now welcome Dr. Daphne Lee with her lecture.
Thank you very much, Dr. Ng, for the very kind introduction. Yeah. So hi, everyone. I'm Daphne, and I'm back again today. Thanks for having me back for a second round. So I think last session we discussed about around diabetic therapeutics, and the discussion centered around some of the newer agents like SGLT2 inhibitors as well as GLP-1 analogs. So today's lecture is about optimizing diabetes care across all life stages. And I thought it would be more meaningful to do it in a form like a case series kind of format. So I'll share a couple of cases from my clinic that I've seen in the last 1 to 2 years that I was out in the private practice, and hopefully it will be meaningful and then for everyone, and hopefully there'll be some useful learning points that you guys can take back after this. So just as a way of introduction, well, we know diabetes is a lifelong condition, and patients have varying needs at each stage of their life. And of course, early recognition and tailored interventions will help improve outcomes in diabetes. And our overarching goal is really to reduce complications and also to improve patients' quality of life. So as you know, diabetes affects all ages. It's not just a disease that affects a certain age group. So, the spectrum of diabetes affects even infants, right? Like, in the form of like neonatal diabetes, young children, preschoolers, primary school, adolescents, and definitely adults and older people as well. So, I mean, generally before the age of 20, right, majority of the diabetic cases are mostly due to type 1 diabetes. And this is some data from the Thai Diabetes Registry, and you can see up to the cutoff of roughly about 20 years of age, more than 50% of cases of diabetes are of type 1. and the incidence of type 1 tends to decrease beyond that age lah. And in terms of type 2 diabetes, right, as we know, the peak incidence of type 2 diabetes is generally in the ages between 50 to 60. But they are increasingly getting younger, and you're seeing more and more younger people develop diabetes. So there's there's an increasing overlap in terms of the presentations, age of onset of presentation of type 1 and type 2 diabetes in a younger and younger population. So we'll dive straight into some case sharing, right? So I have 4 cases to share, and so let's go ahead. Okay, my first case is a young gentleman, Mr. HWX. He's actually a 16-year-old Chinese boy. So my specialty is mainly adult endocrinology. So I don't see that many pediatric cases. But we do see adolescents age group as well, particularly if like they're about 15 or 16. So that's kind of like the youngest age group that I generally see. So anyway, this is a young guy. He's 16 years old. He's a Chinese boy. He's a student. No significant past medical history, but does have some family history of diabetes. Paternal grandfather developed diabetes at around age of 50. And maternal uncle developed diabetes a little bit younger, age of 40. His parents are both non-diabetics. And he was essentially referred for newly diagnosed diabetes. And he has been having osmotic symptoms for 3 to 4 months. And his mother actually noted that there were ends around the toilet bowl. So this is not an uncommon form of presentation for diabetes. These are some of his physical findings and initial lab tests that he came with when I first saw him. So he's very tall. He's 196 centimeters. Heavier on the heavy side as well, 127 kilos with a BMI of 33. He didn't have any stigmata to suggest like any endocrine cause of diabetes, like doesn't look acromegaly or doesn't look Cushingoid. His HbA1c at the point of diagnosis is very high at 13.6%, and he also had some positive urine ketones as well, and normal thyroid function. So this is quite important because sometimes thyroid toxicosis can also lead to onset of newly diagnosed diabetes. So he was actually already seen by a GP prior to seeing me, and he was started on metformin 1 gram daily, which is not an uncommon practice, right? Yeah. So I am a firm believer of CGMS, and I think it really helps patients, and is an important tool when it comes to managing diabetes. So actually, even before seeing me, he already bought his own CGMS, and he started monitoring on his own already. Parents are very motivated, and they spare no expense in terms of his medical care. So generally, when you see a CGMS report, this is kind of like a summary view, right? It tells you like, you know, what is the time in range. So usually I will look at the bar first, right? So you when you set the CGMS, you can actually set a target range, and usually we set it at about 4.9 to 10. Of course, you can, if you want to be more strict, you can set it at a narrow range, right? But usually ballpark is about 4 to 10 lah. So at a snapshot, it gives you basically an idea of how long your patient is actually spending in the target range, whether there are any hypoglycemia episodes, and whether how high the sugars can hit. So you can see, actually, right, he majority of the time, 60-70% of the time, his sugar levels are all above 10, and this was on metformin, right? And he didn't have any hypoglycemic symptoms, and he only managed to achieve target range about 26% of the time. So clearly something needs to be done. So this is his daily log. So when you actually download the report on the CGMS, you will see quite a lot of information. And I find this very useful because it tracks for you the trend of the sugars on a day-to-day basis, hour to hour. So you can see actually the gray bars represent the target range, and this is kind of where you want your patient to land in. But you can see that his readings are all above range, right? Across the day, night, you know, it's all above 10, above 15 generally. Right, yeah. So clearly metformin is not doing the job lah. So in this 16-year-old boy, I think what were my immediate goals when I first saw him? I think firstly, of course, is to control his hyperglycemia, right? To relieve that osmotic symptoms. And secondly, I'm also interested to identify the etiology of diabetes in this young patient, because that may have implications in terms of how we treat him going forward. Of course, the intermediate goal is that we want to achieve HbA1c target, right? And long-term goal would be to maintain HbA1c and to reduce risk of complications. So just briefly speaking, I mean, we are familiar with type 2 diabetes, type 1 diabetes, but there are actually other forms of diabetes as well, right? So type 1 diabetes is essentially due to autoimmune beta cell destruction, and there is basically absolute or very minimal insulin production, absolute insulin deficiency lah. And typically they need insulin, right? And they need basically lifelong insulin. And this is in contrast to type 2 diabetes, right? Which, as we know, is mainly driven by insulin resistance, right? Metabolic syndrome, and is a non-autoimmune mediated progressive loss of beta cell function. Treatment can vary. Mostly oral hypoglycemic agents are effective for managing type 2 diabetes. But of course, there are type 2 diabetic patients on insulin as well. And then maybe the I wouldn't say less common, but maybe lesser known types of diabetes, because it includes gestational diabetes, which is diabetes occurring in pregnancy, is typically diagnosed in the second or third trimester. And because of the pregnancy, right, the treatment options are typically limited to insulin or sometimes metformin, which has been shown to be safe in pregnancy. And then rarely there can be monogenic diabetes, which is diabetes that is genetically, is due to a genetic mutation, and they are inherited in autosomal dominant inheritance patterns. It includes basically MODY, which is maturity onset diabetes of the young, as well as neonatal diabetes. So clearly neonatal diabetes are diagnosed at very, very early stage of life, and they exhibit symptoms like developmental delays, intrauterine growth reduction, they have seizures and cardiac abnormalities. And treatment varies, although there are certain forms of monogenic diabetes that are particularly sensitive to sulfonylureas. And then there's also increasing recognition of other types of diabetes that are related to, perhaps things like pancreatitis or drug-induced diabetes, right? Like, for example, immunosuppressant-related, etc., etc. So this is basically the more or less the full spectrum of diabetes. And I think in this particular patient, right, he's 16, he's fairly young. So I personally, and because he had quite high level of urine ketones, so I want to make sure that he's not a type 1 diabetic, even though phenotypically he looks like a type 2. So sometimes, when you see a patient who's newly diagnosed, sometimes you're asking yourself, okay, he has some features of type 2, yet, he may have some features of type 1. So how do we kind of resolve that conundrum lah? So I mean, we can look at a couple of things, right? So the age of onset, the ethnic distribution, whether there's obesity, whether there's acanthosis nigricans, right? Acanthosis nigricans tends to be a sign of insulin resistance and it's more common in type 2 diabetes, right? Whether there's any ketosis at the onset of presentation. So this tends to be more prevalent in type 1, but type 2 diabetic patients also can sometimes present with ketosis. I think what will kind of clinch it for most of the cases would be whether there's any presence of islet cell autoimmunity. So we would send for the islet cell antibodies or the anti-GAT antibodies, and if they're present, then this is definitely a strong indication of type 1 diabetes lah. And of course, you can send markers that estimate your insulin reserve, like C-peptide, insulin levels, and typically in type 1 diabetes, you would expect them to be low, whereas you would, because of insulin resistance or etc., you generally expect them to be perhaps even high in type 2 diabetes. So for this patient, I sent off all the antibodies, so anti-GAT, anti-islet cell antibody, they were both negative, right? I also did his serum bicarb, which is normal. I didn't do a serum ketose because actually serum ketose is very expensive in private practice. So I kind of have to end up using surrogate markers of ketosis lah. So if his bicarb is normal, it's quite reassuring to me. But nevertheless, because of the osmotic symptoms, the very high levels of hyperglycemia, I advised him to start on Lantus, which is insulin, once a day at bedtime, and I started about 16 units at bedtime. And increase his metformin dose to 1 gram BD. So I think the working diagnosis at this point was this is likely type 2 diabetes with severe hyperglycemia. And so in order to control his hyperglycemia efficiently, right, I would actually preferentially start insulin in this patient and then subsequently perhaps transition to oral hypoglycemics. And it's also important, I mean, the fact that I know that he's, I mean, how do I put it? I mean, the fact is antibodies are negative also tells me that, okay, in this case, the insulin is, it can be just a bridging, right? So once his sugars are better controlled, we can maybe transition him over to oral hypoglycemic agents. Whereas if let's say he turns out to be antibody positive, then you know, I probably will have to treat him like as for type 1 and continue his insulin lifelong even. So anyway, we started on insulin, optimized his OHGAs, and actually kept quite a close eye on him, reviewed him in 2 weeks. So this was his insulin, I mean, this is his CGMS after starting insulin. So you can see that there is some improvement, right? The fasting sugars are kind of coming down from mid-teens to low 10s, and also starting to come down below 10 on some occasions. He still has some hyperglycemia, right, particularly post meals, but overall it's definitely improved a lot. And over time, you know, it continued to improve lah. So you can see the improvement in the CGMS readings. Of course, patients are also very motivated. Parents are very, very supportive, and they also supported him in terms of his, you know, getting him to eat to correct his eating habits, right? Getting him to start becoming active, do exercise, and all this also all this came together to help to basically improve his sugars. So subsequently, the progress of this patient was that eventually I managed to titrate him off his insulin. And because of his, if you recall, his BMI is 33, I counseled him for GLP-1 receptor agonists. And also the reason is that for young people like him, 16 years old, a lot of the, like, you know, SGLT2 inhibitors, DPP-4 inhibitors are not particularly well studied in this group. So the oral options are pretty limited, short of insulin metformin, right? Wegovy has been approved, right, for use in adolescents with diabetes and with weight, that means with weight management issues. And so after a discussion, I started him on Wegovy at the starting dose of 0.25. You recall Wegovy is basically semaglutide, which is a GLP-1 receptor agonist. So 0.25 mg a week, and then subsequently up titrated to 0.5 mg a week, and he has been weaned off insulin. Metformin, I kept it at the same dose, which is about 1 gram OM. Of course, there's still room to optimize that, but we can monitor and see how he goes from there. So yeah, so after starting on Wegovy, actually things look good, right? His sugars are more or less actually within the target range, right? Within the gray zone. Fasting sugars are about 5 to 6, right? Post-meal sugars usually less than 10, so quite satisfactory. Yeah. And also, I subsequently reported his HbA1c, his reactions improved, although I did not put in the result here. So I think in terms of the learning points from this case would be, I think in adolescent patients particularly, it's always important to consider the possibility of both type 1 and type 2 diabetes, right? As the distinction is getting increasingly blurred with rising obesity rates. And we should not rely on just phenotype alone. And if in suspicious cases or in cases that you're not so sure, autoantibodies do help to confirm the presence of autoimmune diabetes. So if you suspect type 1 or if there's ketosis present, do not delay insulin. In fact, even if it's a type 2 diabetes, if they are very symptomatic, you know, HbA1c is very, very high, right? You want to get control early on, and I will discuss this further later, because early control, early intensification does actually benefit the patient in long term. And then, of course, education and empowerment of the patient and family are is a very important factor in terms for, you know, adherence as well as self-management. Okay, I'll move on to the second case, right? So this is a lady, Miss AH. She is a middle-aged Chinese lady, 37 years old, also no past medical history, and can also referred for newly diagnosed diabetes. Similarly, her HbA1c is very high, 12%, and this was detected on routine health screening. She didn't have much symptoms to go by. Triglycerides are also high at 4.7. She also had deranged liver function tests that later turned out to be due to fatty liver. BMI is kind of on the, you know, borderline between overweight and obese or for Asian. And she does have a strong family history of diabetes, especially in her extended family. So overall, it looks like kind of like a type 2 kind of picture, yeah. So yeah, these are some of her investigations. So actually, when I first saw her, I thought she looked a little bit Cushing-noid, and because of newly onset diabetes and everything, I actually screened her for Cushing's. So usually I screen Cushing's by doing something called overnight dexamethasone suppression test, and basically the cutoff is below 50 is normal. So it came back a little bit positive at 62. But I repeated the dexamethasone suppression over a longer period, over 2 days, and it subsequently normalized lah. So I think the initial ODST being high could be a function of her diabetes, and also could be due to the weight, the obesity, which can actually cause like a false positive overnight DEXA suppression test. So anyway, she doesn't have Cushing's. Her thyroid function is also normal, but she declined insulin, which is not a common thing actually in clinical practice. So yeah, despite advice and counseling, she was really very adamant she doesn't want insulin. She just wants to take oral hypoglycemic agents. So I mean, what are the treatment goals in this middle-aged young? I mean, this young 37-year-old lady. So of course we want to achieve her H1C target, and for a person who's this young, we definitely want to achieve H1C below 7%, because this will prevent long-term complications. As much as possible, we want to preserve beta cell function. We want to also, look at her weight, because her BMI is 28. So we do want to, and the BMI is also going to contribute to cardiovascular risk, metabolic risk, and everything. So weight loss is going to be an important aspect of her management. So I mean, if you go back, a couple of years ago, right? Why are we, why do we rely on HbA1c, and why is H1C a treatment target for diabetes? And I think the evidence actually started off from a very early landmark trials, such as the UK-PDS. So the UK-PDS is a very famous diabetes trial, and the original study was done, I think, in the early 2000s, if I'm not wrong. And basically, they look at a very large cohort of newly diagnosed type 2 diabetes, and basically randomized them into a group that had intensive glucose control versus conventional therapy. And they actually followed them up for quite a long period of time, about 10 years. So the key finding from the original UK-PDS study was that actually in the intensive glucose control group, there was 25% reduction in microvascular complications, including retinopathy and nephropathy. And this is significant because we know that diabetes itself does increase microvascular complication rate, right? So this is a very significant finding. But there were no significant reduction in macrovascular outcomes during the trial period. And for every 1% drop in HbA1c leads to a 37% reduction in microvascular risk. So the key takeaway from UK-PDS was that, this is there's robust evidence that HbA1c is a key therapeutic target in diabetes care, and that's why it's something that has persisted till now. And even many years, many decades on from the UK-PDS, we are still using HbA1c as a treatment target. Then there was also some post-trial follow-up that was done on the original cohort, right? Again, over another next 10 years, over another 10-year period. Another 5-year period. So basically, they took the original cohort, right, and they followed them up. So those, and there was no attempt to maintain the previously assigned therapy. So those that were intensive or those versus conventional, they actually basically just follow them up, and they basically they did not make any attempt to control the sugar tightly or not tightly, whatever. And then they basically look at the aggregate clinical outcomes. But what was the key finding in the follow-up of the UK-PDS trial was that this thing about legacy effect and metabolic memory. And they found that those patients who had undergone intensive control early on, right, in the original UK-PDS trial, actually had long-term reductions in macrovascular outcomes and all-cause mortality, even though in the follow-up trial, the HbA1c differences disappeared, meaning that they were intensively controlled. They achieved a better HbA1c in original trial. And then after that, maybe on the follow-up trial, the HbA1c actually became similar to, the HbA1c benefit actually disappeared. But even then, right, because they were because of the intensive control that was happened in the early part of the diagnosis, that actually led to reductions in macrovascular outcomes and persistence in the benefits of the microvascular outcomes. So this tells us that intervening early does have lasting benefits, right? And it's beneficial to intensify early rather than intensify treatment late lah. right? And macrovascular risk reduction may lag behind microvascular improvement. So meaning that, it takes years to actually see improvement in macrovascular risk reduction, but so I think this is something that is an important clinical lesson for us to take away from as well. And this finding about legacy effect and metabolic memory has been replicated across other landmark trials as well, including in that type 1 diabetic cohorts, right? For example, the DCCT and its follow-up trial, the EDIC trial. So so it's not just a one-off finding from the UK-PDS. And they postulate that why this is so, why is there a metabolic, why is there a legacy effect? Why is it that, early intensive control is so important? We know that hyperglycemia basically is pro-inflammatory, right? It leads to formation of anions and pro-inflammatory pathway activation, and that leads to chronic low-grade inflammation, and that damages your large vessels and your small vessels in the long term. And with early intensification, the theory is that it leads to epigenetic modifications, means that it actually modifies your DNA, right? And this actually helps to reduce that chronic inflammation and leads to lasting microvascular and macrovascular changes. And also, there is evidence suggests that, by intervening early, right, the likelihood that your patient is going to have sustained good control is also increased. So this is a study based on a group of patients who were basically taking metformin for 3 months and remained poorly controlled after 3 months. So they were divided into 3 groups. So those who had HbA1c more than 7%, those who were more than 7.5%, those who were more than 8%. And basically after they divided them into a group that this is a cohort study, but they actually looked at subsequently, right, what happened to these patients if they had intensification versus they had late intervention. And they found that in all 3 groups, right, regardless of what is your starting point HbA1c, if you actually intervene early, the probability of having a HbA1c under control actually increases, is higher if you intervene early rather than late. So there are definitely benefits of and of course sustained control is important for overall diabetic control, right? So this is something that is important clinical lesson to take back as well. Unfortunately, as sometimes there exists a lot of inertia when it comes to intensification, right? And we tend to start one OHGA first, then after that wait, and then start a second OHGA, then start third OHGA. So this can actually lead to basically years of patients being above HbA1c goal, right? And this is not beneficial for them, right? So I found that this picture actually illustrates it quite nicely. So, you diagnose a patient, HbA1c is 9, you ask them to diet exercise, then it improves, then it goes up again, then you start one medication, then it comes down, goes up again, then you add. So versus if you intensify early on, right? Overall the time that the patient spends in good HbA1c range is definitely better than if you were to do this stepwise kind of intensification process. And basically by intervening late, right, that results in bad glycemic legacy, right? So the time that your patient spends above with HbA1c above goal actually does drive risk for complications. And it has been shown that this is not without consequence, right? And every year that the patient is delayed in receiving treatment intensification increases the risk of cardiovascular complications, especially MI, heart failure, stroke, and cardiovascular events in general. So I think with this in mind, right, this is a young patient. She has a long way ahead of her, right? Her HbA1c is 12%, right? I would want to basically, I think, rather than approach of like just start metformin, wait 2-3 months, after that increase the dose and wait. I think, I believe that I believe early intensification, of course, it has to be done in a safe manner, right? You don't want to run into hypoglycemia risk as well. So this has to do with, and in order to minimize that, you try to select agents that are effective, yet, don't have high hypoglycemic risk. And of course, basically, you need to follow up your patients closely. So from the get-go, we started her on triple combination. So Glycembi is essentially a combination of empagliflozin and linagliptin at a dose of 10 mg of empagliflozin and 5 mg of linagliptin. So coupled together with metformin. And at the same time, we treated her TGs with fenofibrate as well. So she was treated in February, right? So 1 month later, when I reviewed her, I increased her Glycembi dose to optimize her empagliflozin dose from 10 to 25. I also tried to optimize her glucophage as well. And then we repeated her lipid panel. Her LDLs were high, so she had to be added on a Crestor, which is rosuvastatin. And then we basically optimized further, and then subsequently, with this, we call her weight is her BMI is 28, right? So weight loss is also important part of her management. So after discussion, we switched her over to Ribelsus, which is oral semaglutide, and Zigduo. Zigduo is basically an SGLT2 plus metformin. So when we give GLP-1s, we usually do not give it together with DPP-4 inhibitors because it constitutes a therapeutic duplication because they are both incretin-based therapy. So when I started her on semaglutide, which is the Ribelsus, I had to stop the Glycembi because Glycembi contains linagliptin, which is DPP-4. So I just kept the SGLT2 and the metformin. So this is a CGMS. So this was before treatment, right? So at diagnosis, as you can see, just like the earlier patient, the sugars are all over the place. It's 20s across the day, right? And then she's a very diligent patient. So she records, what she eats, what she does, puts in a lot of useful information within the CGMS. And you can start to see some improvement in her sugars when treatment was started. Right, so this is about maybe a few days later, right? So actually, you can see the treatment effect is quite rapid, right? Yeah, and this was maybe about 3 weeks or 4 weeks later. You can see there's a huge improvement in her sugar levels. Of course, there's still some spikes postprandial, right? It can go up to 14, 15, but overall, actually, her sugars have come down significantly, and this was like 2 months later. Can see that actually she's maintaining quite good levels of sugar. I mean, there again are still some spikes and her fasting sugar is still a bit high, but overall, compared to when she was first diagnosed, it has improved tremendously. So these are her follow-up blood results, right? So you can see at the point of diagnosis, January 2025, H1C was 12.9%. In March, it has come down to 10.6%. Of course, improvement, but not at target yet. And then by May, which is about 4 months after treatment, she's getting close to 7%, right? 7.6%. In July, it was 6 months after starting treatment, she managed to achieve 7%. And then now, after about 9 months or 8 months of treatment, she has achieved a H1C target of 6.6. LDL has also improved significantly after Crestor. Similarly, her TG levels have also come down with fenofibrate treatment. She also had fatty liver, and with control of her diabetes, improvement. I didn't put her weight in, but her weight has also improved, and so along with all this, her metabolic parameters have actually improved significantly. So I think the learning points from this case would be, in a newly diagnosed patient, early glycemic control is critical, right? Try to avoid therapeutic inertia. There is some evidence to show that combination therapies may be superior to stepwise monotherapy. So combining treatment early, like SGLT2 with a DPP4, right, and actually that particular combination has been shown to be quite effective, especially for sugar lowering, especially Asian patients. So consider combination therapy when appropriate. Of course, lifestyle and patient education is very important. We need to address that right from the start. And I find it important, and I guess being in private practice, I do have the luxury of reviewing my patients very closely. So I review them quite regularly, like 2 weeks, 4 weeks, And so we can escalate treatment promptly if the targets are not achieved. Okay. So let's move on to a third case. So we've seen a young patient we've seen two patients with newly diagnosed diabetes, right? One young, turns out to be type 2. The other one a bit older, also turned out to be type 2. So let's see this patient. So this is Miss A. She's a 45-year-old Chinese lady, smokes and drinks socially. She has history of pre-diabetes. In fact, there was noted health screening 1 year ago, but she was treated conservatively, meaning diet, exercise. There's some family history of diabetes. Both maternal grandparents are diabetic. Also, again, referred for newly diagnosed diabetes on health screening. And this time around, her HbA1c is 11.7%, with again a very high level of fasting glucose. Very classic osmotic symptoms with weight loss, polyuria, polydipsia. And the interesting thing about her was that actually 2 months before her diagnosis, because her partner has diabetes and so he does regular hypocount check. So out of curiosity, she checked her hypocount post-meal, just randomly a few months before her diagnosis was made. And actually a postprandial hypocount at that time was 5, which is very good actually. But then, in 2 months, it actually went up to more than 20. So this seems to suggest a very rapid onset of diabetes. So these are some of her other parameters. LDL is also a bit on the high side. Creatinine and liver function are normal. Bicarb a bit on the lowish side. Her insulin levels are very low for a glucose level of 17. So that is another kind of like ring a bit of alarm bells. Vitamin D is also a bit deficient. Thyroid function is normal. And then she also has a slightly raised CEA at 6.2. So I think at this point, the considerations was, what went through my mind at that time was like, okay, this may not be a straightforward diabetes, right? Things that kind of like made me sit up and pay a bit more attention was the rather rapid onset of severe hyperglycemia, actually, in a rather short period of time. With a little bit of a lowish bicarb and then low insulin levels, and then this CEA, which is a little bit high, not sure whether is it, something that is of that could lead to something serious or not. So these are kind of some of the thoughts that are going through my mind at that time. In any case, prior to seeing me, she was already started on glargine, which is good, right? Glargine is a basal insulin. Started on a small dose, 8 units once a day, and then also metformin XR 500 mg BD lah. So yeah, as I mentioned, what made me sit down and pay attention in this case was a rapid worsening of hyperglycemia on the background of pre-diabetes with this raised CEA. So when we see patients with this kind of presentation, right, or like say someone who has very stable diabetic control and then suddenly deteriorates, it makes us worry about pancreatic cancer lah, right? Because due to the solid tumor itself that can cause rather rapid onset of like insulin deficiency, and typically they have like a pancreatic diabetes, which is behaves very similarly to, it's like akin to type 1 diabetes kind of thing. The other thing that is of concern is whether does she have LADA, which is latent autoimmune diabetes of adulthood, which is like a variant of type 1 diabetes. Some of the other things that can cause rapid, or sudden HbA1c deterioration is medications. So if someone started on steroids, right, can actually jeopardize somebody's diabetic control. And also whether there are other endocrine conditions like, did she develop thyrotoxicosis? Did she, develop Cushing's or acromegaly or something? So she doesn't have any stigmata, right, to suggest that she doesn't look acromegaly or Cushing. So I think that is of a lower concern. So this again is a CGMS, right, all over the place, high all the time, right, and sometimes goes, and I think what is a bit different in her case is the rapid swings. So it can go high one moment and then give it insulin, it drops, sometimes drop to hypo range and then it goes up again. So this is very typical of a very type 1 kind of presentation. So anyway, even though she's 45 years old, right, because of all the things that I mentioned earlier and the points in history, I sent her her insulin antibodies and it turned out positive. So anti-islet cell antibody was positive, C-peptide was low, GAT was negative. So essentially, she has been treated like a type 1, and the diagnosis was basically, I thought she had LADA, right? Because background of pre-diabetes, background of, what seems like normally sugars 2 months ago and then suddenly deteriorates, right? She also actually was also concurrently being seen by the surgeon because of the high CEA. She was scoped, and then she also had scans. There's no pancreatic mass, there's no malignancy that's been identified. Yeah, so that was reassuring because that's something I wanted to, we needed to exclude as well. So we intensified her insulin essentially, right? So added on a bolus insulin in addition to glargine, had to ramp up her basal insulin. But it's very challenging, right, to control her sugars. As you can see, it's up and down, right? High one moment, low one moment, hypo one moment, hyper one moment. So this is very typical type 1 kind of behavior, and it's always very challenging to manage these kind of patients. So anyway, I brought up this case because I wanted to, highlight a case of LADA. Right? LADA is essentially autoimmune diabetes that initially mimics type 2 diabetes, but it's actually caused by autoimmune destruction of pancreatic beta cells and is similar to type 1 diabetes. And because the beta cell loss is gradual in these patients, they may not typically require insulin immediately, but they usually would, deteriorate and become insulin dependent within months or within just a short period of years. So the difference between LADA and type 1 and type 2 are firstly age of onset. So type 1 usually occurs in younger people, right? Like below age of 20. LADA tends to occur maybe in a bit older, right? They can occur in adults between 30 to 60. In terms of onset, right? Type 1 diabetes tends to have abrupt onset. They present in DKA, present very hyperglycemic. LADA may have a little bit of a more gradual kind of onset, maybe a little bit similar to type 2 diabetes. In contrast to type 2 diabetes, autoantibodies, right, like GAT antibodies, islet cell antibodies are typically present, just like in type 1. Insulin requirement may not be immediate, but they eventually do need insulin lifelong. And body habitus is also a useful thing to look at, right? So in LADA and type 1 diabetes, the patients are typically lean, in contrast to type 2 diabetes, in which the patients tend to be a bit more on the heavy side. So I think this case, the learning point would be that, in a type 2 patient who's lean, right, very active, physically active, or deteriorates very quickly despite good adherence, do think about LADA, right? We can confirm the diagnosis with, again, antibody testing. I usually would send both the GAT and islet cell antibody because sometimes they may be GAT negative but other antibody positive. And the important thing to remember in these cases is that we need to initiate insulin early because this is very crucial to preserve beta cell function and prevent complications like DKA. And then broadly speak, and to think a bit more broadly, right? LADA being an autoimmune condition may coexist with other autoimmune conditions such as thyroid disease, right? Pernicious anemia, and so or even Addison's disease. So in patients with LADA, right, besides managing their diabetes and all, sometimes at the back of our minds, you need to think about whether you need to screen the thyroid, screen the cortisol, screen the B12, and things like that as well. Okay, this is my last case, right? So this is a little bit different. This is an older gentleman. 63-year-old gentleman, he is has been diabetic for a long time, right? 20 and 30 years of diabetes, has multiple comorbids, including hypertension, hyperlipidemia, minor CAD, also has diabetic nephropathy, recurrent UTI and urinary stones, right? And also a slip disc for which he has back surgery done before. So he was referred for diabetes management and optimization. So these are the medicines he's on. He's on Janumet, which is a combination of Januvia, which is sitagliptin, and metformin. He's also on dimicron. So his medications for diabetes are actually quite optimal, right? With the Janumet dose about 100, which is max dose really. Metformin is about 2,000 mg a day, which is also quite a decent dose. And then dimicron dose has been more or less optimized. He's also on other things like coeprovel, sotalol, Crestor, epicebana. So actually his HbA1c is not too bad. It's 6.6%, right? He's very he's quite on. He does home BGM, but unfortunately only does fasting hypocounts. He doesn't do postprandial hypocounts or pre-dinner hypocounts. But anyway, his fasting hypocount not too bad, 6 to 8, right? Sometimes 8 plus, no other readings. He says there are no hypo symptoms. And it's generally quite careful with his diet lah. So like I said, I'm a believer of CGMS, so I put him on CGMS, and because I wanted to see, given he's already on quite good number of OHGAs, right? Is there anything else that I can optimize? And as you can see, when I put it on CGMS, you can see that he has actually having a lot of hypos lah. Yeah, so they're quite so he's been having like overnight hypoglycemic episodes, and even though he's asymptomatic, it was picked up on CGMS, right? Right. So not just overnight. So sometimes even like before bedtime or post dinner, he's also been having quite a number of hypoglycemic episodes. So we mentioned earlier about UKPDS and the importance of HbA1c, importance of early intensification. So, after the UKPDS study came out, right, there were a lot of interest in seeing how low can we go, right? Is 7% enough, or should we go as low as 6.5 or 6%? So it's the question that was on everyone's minds was that, is tight control better, right? Like LDL levels, right? It just keeps getting lower and lower and lower. So this is the ECHORD trial, right? And it's a landmark study published in 2008 that basically kind of aim to answer this question. And it's a large trial involving 10,000 patients, right? With quite long duration of diabetes, about 10 years. And all of them had very high cardiovascular risk. So either they had multiple risk factors or they already had established cardiovascular disease. And so they randomized them into two groups. One with intensive glycemic control, meaning they aim HbA1c below 6%. And the other group was just maintained on standard therapy with a HbA1c target of generally 7 to 8. So basically, the main outcome that they wanted to examine was whether there was any cardiovascular events, so like MI, stroke, or death from cardiovascular causes. So this study was actually halted early, right, because of the increased risk of death that was being observed in the intensive group. Right, so you can see that actually the hazard ratio is 1.22 for death from any cause, particularly death from any cause in the patients that actually were randomized to the intensive therapy group lah. Yeah, and in fact the rates of death between the two study groups separated after a year, right? And throughout the follow-up period, the differences persisted. And this effect on mortality was consistent within subgroups, right? So regardless whether you're male, female, young or old, HbA1c good or bad at baseline, they had the effect of intensive therapy on the risk of death seems to be consistent. And so if we compare the HbA1c being achieved in the standard therapy group and intensive therapy group, then you can see clearly there's a clear difference, right? The standard therapy averaging HbA1c about 7.5 and the intensive group therapy averaging about below 6.5%. And what was significant was that the incidence of hypoglycemic episodes was much higher in the intensive group versus the non-intensive group. And so this ECHORD trial is a frequently cited study that basically sends a warning to us that in patients of high risk, right? Patients with long-standing diabetes, very high cardiovascular risk, whether tight control actually does more harm than good, right? And by controlling their sugars tightly, you actually cause a lot more hypoglycemic events, and that actually is quite detrimental for them. In fact, increases risk of death. So I think going back to the patient, right? So his HbA1c looks seemingly very good, 6.6%. But actually, if you look at it, if you actually take a closer look at it, you actually realize that actually this is at the expense of him having quite a number of episodes of hypoglycemia. So the immediate goal for me was actually to eliminate his hypoglycemia, right? And then, of course, intermediate goals would be to control his sugars, right, while minimizing hypoglycemia risk. At the same time, try to reduce polypharmacy because he's on quite a number of other medications as well. So what I did was that I reduced his dimicron dose. So among all the medications that he's on, Januvia, glucophage, dimicron, I think the one that is the probably biggest contributing culprit to hypoglycemia would be the sulfonylurea. Right, so I basically just cut down his dose gently and cut down the night dose from 60 mg to 30 mg, try to eliminate his nighttime hypoglycemia, and then maintain him on Januvia or glucophage. We also did have a discussion about alternatives like SGLT2, GLP-1s, right? So whether we can substitute his dimicron for some of these newer agents that have lower risk of hypoglycemia. But then, he's a history of recurrent stones and frequent UTIs. In fact, he's also on long-term antibiotics because of his frequent UTI history. And so definitely SGLT2 inhibitors are not suitable for him. In terms of GLP-1s, right, I think there will be benefit for him because he does have cardiovascular history, and GLP-1s have been shown to be beneficial for cardiovascular protection, renal protection in diabetic patients, particularly those with high cardiovascular risk. But there was a cost concern, right? So the options that we had were rather limited. But in any case, we continue to maintain him on Januvia, glucophage, and dimicron, and that seems to kind of strike a balance between getting good glycemic control without causing too much hypoglycemic episodes. So subsequently, when I monitor him, his subsequent HbA1c came up to about 7%. So from 6.6 to about 7%. And I think that would be that would be a comfortable range for me to keep him at about 7 to say about 7.5, rather than to try to bring him down to below 7% or even below 6.5%. So I think the take-home points from this case would be that in older patients, right, especially those with multiple risk, multiple comorbidities, right, we need to balance the HbA1c targets, right, with safety, right, and sometimes the quality of control matters more than the number itself. And sometimes you need to be wary of a normal HbA1c, right, so that can sometimes mask frequent hypoglycemia or wide glucose variability. So therefore I find CGMS very helpful. So if the patient has frequent hypoglycemia, that is a signal for that the patient is overtreated, and this increases morbidity and mortality risk, right? So the intensification, individualization of therapy is key indeed in older patients, right? And of course, tight glucose control is only one aspect of cardiovascular risk management. So we need to look at the other things as well. BP, lipid, smoking cessation, weight optimization are also equally important. So I've come to the end of my talk, right? I hope the 4 cases were useful, and hopefully there are some useful points that you can take back. But I guess these are some of my take-home messages. So I think in terms of diabetes, right, always patient-centered care, right? So it's not a one-size-fits-all thing. We always aim to individualize glycemic targets and treatment strategies. Education and self-management is extremely important. And I think part of education and self-management involves getting a patient to really check their sugars diligently at home, whether it's through finger prick or whether it's through CGMS. And of course, this needs to be tailored to the age, literacy, and the cognitive function of the patient. Lifestyle, always important, right? Diet, exercise, and I think we also starting to understand that sleep and stress management is also very, very crucial, right? Medication optimization, right? So using medication efficiently, right, with tailored to the patient's needs, right? So inpatient, it's also use agents with proven cardiovascular renal benefits, especially when indicated. And then, of course, it's important to regularly screen patients, for microvascular and microvascular complications. And last but not least, right, the psychosocial support, right? So mental health, adherence, and involving the family, the caregivers is also a large part of optimizing diabetes management at the end of the day. Okay, that's the end, right? I think we
We
ended
have time.
time. Yeah.
Thank you
Okay.
so
Yeah, I
much.
hope it was not too. Yeah, I hope it was not too boring. But I thought,
No.
I thought maybe use some real life clinical cases to illustrate points would be a more useful approach, lah. Yeah.
I
So
really like the
yeah.
way you use case studies because all these cases, increasing ages and all of them have got different messages and different lessons. Like the first one, young person doesn't mean it is type 1, right? And then
Yes, that's right.
and then the third case, an older 45-year-old doesn't mean it is type 2. And also you
Yeah.
taught the important lessons about intensifying treatment early. But one of the lesson I learned from your sharing is the magic of CGMS. You mentioned you believe in
Yes.
CGMS, but all these are possible because you use CGMS. And there's one question related to postprandial glucose monitoring. Maybe I'd like to ask you, for CGMS, is there a discrepancy between CGMS and actual plasma glucose? How do you, like, if there's a hypoglycemia on CGMS, does it mean that he is really hypoglycemic, or is there could be some kind of error? And
Yeah.
how would you address this?
Yeah. So that's a very good question, and it happens frequently. So CGMS measures interstitial glucose. That's different from plasma glucose, right? So there will be some lag. So let's say your plasma glucose is 3.2 or something like that. Your interstitial glucose may not be 3.2 immediately. So there's some lag and there's some difference. So CGMS is also not without its problems, right? And of course, technical issues are one of them. And yes, sometimes especially when you first start, so CGMS is about 14 days, right? So
Yeah.
14 to 15 days. So sometimes when you first insert, right, the first 1 or 2 days, you may find it reads a little bit low,
Yeah.
right? So especially overnight, I don't know, sometimes because of the posture or the pressure on it. So sometimes the reading may be a bit off lah. So
Yeah.
I always tell the patient, so if let's say the CGMS alarms, right, beeps you and say, oh, sugar is 2.9 or something. So first thing is, are they symptomatic or not?
Yeah.
Right? So if the sugar is 2.9, you expect them to probably have some symptoms.
Yeah.
And if let's say they are feeling actually quite fine, they're asymptomatic, I always ask them to keep a glucometer to stand by at home. So that is to basically corroborate the readings lah. So I ask them to check, right? So if let's say the CGMS is reading 2.9, and then they do a finger prick, right? Maybe it's 5.0 or something, and they're feeling perfectly fine. Then I would take the CGMS reading with a pinch of salt. Yeah, so it is also fraught with some technical issues, particularly this hypoglycemia. So I think it takes a little bit of a judgment lah, right? To kind of like know whether is this real or is this just a technical kind of thing. So sometimes when you if you try it yourself, right, the CGMS, you'll notice that how come first 2 days it always read a bit low, like my sugar low, but I feel okay. Then after that it will be okay. After that it will kind of like I don't know, kind of self-calibrate or what, and then the readings will be more stable and more steady. So sometimes it takes time for it to kind of like kind of calibrate lah.
Yeah.
Some of the brands like Buzut will allow you to calibrate. So that means you find the reading a bit wonky, right? Then you check a hypocount lah. Then you can actually key in your hypocount number, and then the sensor has a way to calibrate, and then the readings will kind of get. So that's some of the things that we encounter when we do CGMS.
Thanks a lot. I use
yeah,
it for I get hypoglycemia at night. So I thought, is that normal? Maybe it's normal because I feel well. So
correct. Yeah, I actually got patients who come to me because their friend asked them to put CGMS, then they go and put, then they got scared, because the reading like a whole night very low like that. So they thought that they had some hypoglycemic disorder or something like that. Yeah, but actually it turns out to be not really the case lah. So if you find that the readings are not congruent with clinical symptoms,
Experience.
right?
Yeah.
Yeah, then is you need to do you can check, you can corroborate with a glucometer. So actually it's not that it totally takes away the need for glucometer lah. So
Mm.
I still tell my patient, yeah, CGMS is very convenient, right? You don't have to prick, and it can track your sugar even when you are not checking, like when overnight,
Yeah.
that kind of thing. But it's still good to keep a proper glucometer at home as a standby. Yeah, so in case of situations like this,
Thanks. I think it's a convenient segue to the first question by, I believe it's a Dr. Teo. Postprandial hypocount. He would do it 4 hours postprandial. What is your recommendation if you only wish to exclude type 2 diabetes? What is considered positive? Diagnose type 2
Um,
diabetes by this, right? Yeah.
no, we don't diagnose type 2 diabetes through hypocount
Yeah.
but generally for diabetic patients, we ask them to check pre and post 2 hours apart lah.
Oh, okay.
Yeah,
So generally
about 2
2 hours.
hours apart. Yeah, so yeah lor, usually not as long as 4 hours. Usually about
Okay.
2 hours apart. Yeah.
And the second question is related to the first case, the young man with a type 2 diabetes. You mentioned about
Yeah.
excluding some kind of endocrinologic disorder, acromegaly and all that, but this person seemed to remember you mentioning about thyroid conditions. Is there a link between thyroid problem and diabetes?
I think the link is also in terms of autoimmunity. So, type 1 diabetes is basically autoimmune condition, right? And when you have one autoimmune condition, sometimes they also have other autoimmune conditions. So, the thyroid is very important. Thyroid is always typically a common autoimmune disorder. So sometimes they can occur together. So I think that's one reason why I will screen the thyroid. Secondly, is also patients who have thyrotoxicosis or what, sometimes they may have their blood pressure goes a bit high, sugar level, so maybe a bit. I mean, it's not like it's not like the thyroid leads to. I mean, we seldom see thyroid alone causing diabetes. Usually, is like they probably would have some sort of like type 1 diabetes or maybe just type 2 diabetes. But I would check a thyroid for those reasons that I mentioned. Firstly, because thyroid is also another autoimmune condition that is commonly associated with other autoimmune conditions like type 1. And secondly, just to exclude some secondary causes. Yeah. So, yeah.
I see. There's a question about working in Cambodia. I'm sorry, but I think it's not really relevant, so I won't ask it. But there's a question about HbA1c of 10 on Jardiance 12.5 and 1000, and diamicron 60 and linagliptin 5. So for OHGA, BMI is 21, which sounds good. I think the question is, how do you start basal insulin? I also had the same question. The Lentus, for the first case, you started at 16. And for the third case, type 2 diabetes, glargine, you started at 8. So how do you decide how much baseline insulin to start? Is it based on body weight or based on the presenting hypoglycemia? The glucose level. And for this Georg Lim's patient, how would you start insulin?
So I think a useful rule of thumb is to go by weight base. Yeah. So you can start like 0.2, 0.3 unit per kilo.
Okay.
Right? So then you can adjust, like that can be a base, then you can adjust based on, how do I say? A bit based on
CGMS.
feel lah. Yeah, CGMS, correct. Yeah. So I mean, you don't want to start like a huge dose, then the patient suddenly hypo, right?
Yeah.
But you want to give a pretty effective dose as well. So generally, I find, and also you can get a clue from the ambient sugar. So it come to you with sugar 22, 25. Of course, 4 units, 6 units is not going to cut it lah.
Yeah.
Right. So it's a combination of like the weight,
Yeah.
and also the ambient sugars, and how high the HbA1c is, a diagnosis, and whether you think this patient is high risk to get hypo, or that kind of thing. Like maybe he's also on dimicron or something, right? Then you may want to adjust accordingly, maybe minus 2 units here, 4 units here, or just to account for that. And then I think the key is monitor it closely, so either through CGMS or get the patient to self-check and adjust the insulin doses from there. Yeah. So actually the
CGMS
going to
allow us
say,
to be more. Yeah, sorry, please go ahead.
no. So actually the third case, Actually, in that case, the glycemic unit was started by somebody else,
Oh,
which
okay.
I felt was too conservative. Even her sugar is hitting like 27, 28,
Yeah.
I can't remember. So I felt that was too conservative. So when I saw her, I actually I increased it lah. I increased it to I
Yes.
think about 12 or 16 around there. Yeah.
I
So
think for me, I also be very
so
kia
yeah.
also. But if with
Mm.
CGMS, it's a bit better lah. At least they can continue to monitor.
Yeah, so I find CGMS is basically data gathering. So it serves a few purposes lah. One is that it basically serves as how to say, patient can actually see how their sugar behave like in
Yeah.
real time, right?
Yeah.
So and without having to prick themselves frequently.
Yes.
Yeah, so I think, you know, sometimes just by doing CGMS for 2 weeks, right? The patient's sugar actually self-improve. So I've had cases
Yeah.
where they come to me, sugar like mid-teens, 15, 16, approaching 20. Then after 1 week of CGMS, you actually see the sugar start coming down.
Yeah.
Not because I give new medicine or I up titrated their medication, but by the sheer fact that they can actually see their sugar in
Yes.
real time.
Yes.
Then they realize that, wow, I eat this thing, or I do this thing, my sugar go up so high. Then they know what they actually realize it lah. They see it for themselves what actually things does to their sugar or certain food does to sugar. So I think that is a very visual reminder for the patient. And then of course in patients who are, you know, on insulin, in patients who are on like multiple OHGAs, right? Then it is very useful for medication titration as well.
Yeah.
Because I mean realistically speaking, nobody's going to check their sugar 24 hours a day.
Yeah.
So and then when you follow up patient, you only see the HbA1c every 2 months, every 3 months. It's just an average, right?
Yeah.
So you don't know this patient maybe hypo, then hyper, then average out in the middle. So I personally am a strong believer in CGMS, and I think it's a game changer in many
Yes,
sense
it
of
is.
the word for diabetes management. Yeah,
Mm.
yeah. Mm.
So there are a few questions related to LADA, the late onset adult diabetes dependent, whatever diabetes. So are this group of people dependent on insulin for life? And would this group experience regenerating or regrowth of beta cell? Can it be reversed? Is it adequate enough to just use OHGA for sugar control, avoiding insulin?
Cannot leh. LADA is basically like type 1.
Yeah.
Yeah, it's basically like type 1. So they need insulin long term. I don't think there's a chance of reversal.
Yeah.
OHGAs cannot. Yeah,
Okay.
usually they basically behave like type 1 lah.
Okay.
Mm.
So I think Gyok Lim asked about the same question about the person on 4 kinds of OHGA, and yet the HbA1c is 10% about starting insulin. She followed up a question.
Yeah.
In my case, if you don't want to start insulin, worry about hypoglycemia, what else can I add?
Oh, okay. So if I recall, the patient is really on most things,
Yes.
right? Metformin, SU, GLP, not GLP, SGLT2,
Yeah.
linagliptin.
Jardians.
I think I think firstly optimize all the doses if the patient can tolerate.
Yeah.
But to be honest, at this point, the oral options are quite limited already. Unless you want to start a GLP-1, you know, which have oral form or injectable form, or you know, other older medications like acarbose, that kind of things. I mean, I think very few people use it nowadays. A lot of side effects and very expensive also.
Yeah.
So to be honest, if your patient is on 4 OHGAs and already all maxed out, HbA1c is still bad, I think need to think of insulin or injectable like a GLP-1 or something already.
Yeah.
Sometimes cannot avoid that. Yeah.
I think there's a question about a person with irregular meals. Perhaps we can add like irregular meals and yet you're on insulin. How would you advise? How would you manage?
Yeah, so irregular meals are challenging. Of course, the most ideal insulin regime would be a basal bolus. So that means you know, you give a basal and then you give a bolus before every meal. So it's flexible in the sense that you can, so it doesn't have your fixed timing lah. So that means if I eat at 8 a.m., then 3 p.m., and then 9 p.m. or something, I just give the bolus before every meal lor, right? So I think that would be the most ideal. But of course, that involves patient have to inject very frequently. and some patients are okay with that, some patients are not okay with that. I mean, the pre-mixed out insulin, I find it's convenient, but doesn't offer that kind of flexibility.
Yeah.
Right. So if a patient really irregular meals, I will try very much to try to get them to go on a basal bolus regime as much as possible if they are willing to do so.
And CGMS will
if
help,
they
right?
are- yes. Yeah, of
Yeah.
course. Yeah.
Yeah, it's very
Yeah.
useful, CGMS revolutionized our
Mm,
management. Yeah. Okay.
mm.
So maybe with that, we've answered all the questions. And really grateful for Daphne. Very last minute, and I just texted her, and then she agreed to do 2 talks. And yeah, I'm really, really grateful. Thank you very much, and I learned so much
Oh,
from.
you're most welcome. Most welcome.
Yeah, and I heard last
My
month
pleasure.
talk about the different kinds of diabetic medicines was a lot of us it's like really shocking because in the community, we not in the hospital practicing, we are very outdated on the most current management of diabetes. So this was really useful what you've shared. And yeah. And maybe I also have a message for the audience here. We are going to have a hibernation for 2 months. The November and December, we won't have anyone speakers arranged. We've already doing this for the last 2 years and 8 months, and I'm running out of speakers. So later, when you're giving your feedback, please give me some ideas who you like me to invite for this webinar. And so for the next year, from January onwards, we designed this webinar because many of us working in the community, long-term care, aged care, we are a bit out of touch with what is practiced in the hospitals. We like to update ourselves, but yet at the same time, many practice of medicine to really apply in community, in aging, in frailty, and in palliative situations are not entirely so clear. What we learn in the hospital, we apply in the community. So we like to also learn on topics that is really important for this group of patients. Yeah. So if you have any suggestions, please give me when you're doing your feedback. And thank you. So maybe Christina, would you like to give a closing remark?
Thanks everyone for joining us this afternoon. So after the break, I hope that we will see you again in the next year, and you will join us for our HNF 50th anniversary celebrations. Thanks everyone.
And thanks, Steph.
Thank
Okay,
you.
bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye.